information as well as advances in the diagnostic modalities and newer investigations coming up, the profile of patients has changed over the decades, particularly the last 3 decades. So Dr. Noel will tell us about the trends of illnesses presenting as FUO, our own observations as well as those from the literature. Imaging and image-guided interventions play a very crucial role in the evaluation of these patients. Dr. Smita will tell us about the role of various investigative imaging modalities in the evaluation of FUO. Nuclear medicine has played a very important role for ages. I remember as early as 80s, there was indium, various isotopes, indium, technetium, gallium scan. But in the end, advent of PET, positron emission tomography, these have taken a little backseat. Dr. Rakesh Kumar will tell us the role of this is an emerging modality for the evaluation of KU, and he will tell us more about it. The various atypical pathogens or uncommon pathogens, which we don't think about in the beginning when these patients come to us, and some common pathogens which evade the detection by the common diagnostic techniques is something very puzzling for us very often as a cause of FUO, and Dr. Rama Chaudhary will elaborate on this. And finally, I'll sum up on how to approach a patient when we come across who presents to us with prolonged undiagnosed fever. And I hope we'll have adequate time for questions and answers. Let's start with a scenario. A 30-year-old lady, a housewife, presents with 2 weeks history of high-grade fever. The only other history is a possible rash on the legs. And the only medication she's taking is oral contraceptive pills. The physical examination is unremarkable. So the question arises, does she fit into the criteria of fever of unknown origin? 10 seconds, anyone? Louder? No. Good. Okay, why and why not? We'll talk about it. Definition of FUO. Now, if you look at this, somebody said, rightly said, I think there were many voices said, no. It's important to remember that not every fever with unclear cause or source is FUO, fever of unknown origin. It's actually a term coined for ongoing and enigmatic. When we say enigmatic, it means it's a puzzle, problem, febrile illnesses. It's a term used specifically for ongoing and enigmatic febrile illnesses. Now, every condition requires a definition for epidemiological studies, for example, and also when you want to plan an approach. So, Petersdorf and Beeson in 1961, through a report of 30-page report on 100 cases on fever of unexplained origin, coined this definite from those 100 patients that anybody who had a fever of more than 3 weeks duration with temperature higher than 101 degree Fahrenheit on several occasions, and diagnosis remained uncertain after 1 week of inpatient evaluation for the patients who would be classified as fever of unknown origin. The reason for 3 weeks being that most of the self-limiting illnesses or illnesses which are unable to treatment with the short-term treatment with drugs would be treated. That was the premise behind this. And temperature higher than 101, again certain kind of habitual hypothermia or physiological conditions like or fictitious fevers is something that could be picked up. So if they had a high temperature, more likelihood of not including those, and of course several occasions. Now with advances, with increasing cost of hospitalization and also the newer diagnostic modalities and tests being available on an outpatient basis rather than only inpatient, they revised their own definition in 1992, recognizing the acceptability of outpatient in place of inpatient evaluation. Around the same time, around 1991, Durek and Street proposed little modification in this definition. But clearly for classic definition, they further reduced the duration of investigation to 3 outpatient visits or 3 days in hospital. We'll come to this. Is it feasible in our circumstances? And of course, they proposed that FUO could be classified into 4 categories, and the other 3 being neutropenic, nosocomial, and HIV-associated. So these terms are very explanatory, and I'm sure the audience here recognizes neutropenic who have less than 500 or have a probability of going into this in the next 1 or 2 days, and nosocomial which are in the hospital. Now we are dealing mainly with this, and I will just move on from here because we are not going to talk in this background on FUOs in the immunocompromised patients. In this situation, as we see, these are 3 days. It's not 3 weeks, it's 3 days, and most of these patients would have conditions which could be life-threatening. So these are the situations where an early antimicrobial therapy would be justified in these 2. So I just now, if you look at the definition of FUO of 101 fever, now this is something which has been challenged and even we have observed that very many patients who have a temperature of less than 100 degree or low grade fever actually turned out to have illnesses which were of serious pathological consequences. So, and none of these studies actually point to, what kind of temperature. Is it oral, is it axillary when we're talking of values? So there are no studies which mention this. And there are, so for all practical purposes, if you have an AM temperature of more than 99 degree Fahrenheit and a PM temperature of more than 100 degree Fahrenheit, it could be taken as fever in this sense of, for classifying them as fever. The second was the duration of 3 days and 7 days. Now, if we look at the various healthcare facilities, so you have corporate hospital where the patient could be investigated in 2 days, because there is cost issues are not a major issue, and of course the availability, and it could take months. So therefore, the contemporary definition of classic FU that has been used in most of the recent studies is, of course, illness of 3 weeks duration, temperature of more than 101 or lower, when the lab features suggest some evidence of inflammation on several occasions, and no diagnosis reached after initial and relevant diagnostic investigation. It is not 1 week or 3 days, and after exclusion of nosocomial and severe immunocompromised state. Now, what is that relevant evaluation? I'll just quickly go through this minimum diagnostic evaluation to qualify as FU. Comprehensive history. Now, in these patients, there is nothing which can undermine the value of history and examination. But in these cases, special aspects like travel history, history of pets, occupational issues, prior surgeries, family history would be very important. And one needs to pick up subtle clues. Similarly, a very thorough physical examination from head to toe would be very important. And we presented recently a CGR, little discomfort, and you can find the source of fever there, sitting there, which is mixed on other things. I will have to be a little quick. So this is something which you are all familiar. I see a lot of student and resident population, and I'm sure this is an area which this is where they keep work every day. Why biochemistry is important? Let's say alkaline phosphates can give you clues. Calcium, hypercalcemia can give you clues. High uric acid can give you clues. So this is the basic evaluation which every patient must undergo. And an X-ray chest and ultrasonography are the screening radiological techniques that are essential. Tuberculin test, yes, if it is strongly positive, it does give us clues in the appropriate settings, and the further evaluation should be directed by the abnormalities on the above tests. Symptoms and signs would be highly variable. They could be very trivial in low-grade fever, patient may be well preserved, appetite good, weight maintaining. It could be very debilitating. People come across with very high-grade fever, with high catabolic state, severe debilitating that they are bedridden. So there could be manifestations of fever. You may or may not have underlying disease reflection in the symptoms. So it's very important that every subtle symptom or sign that you see should be used as a potentially diagnostic clues, and your evaluation should be directed towards that. Some of the common causes you will see later in the series that 3 common subgroups that we finally these patients are diagnosed as are infections, malignancies, and non-infectious inflammatory disorder. We'll see, look at the trends when the others tell us about the profile. Now you see, if you look at the diseases, they're not very uncommon. Most of them are extrapulmonary tuberculosis. We still see as common abscesses still despite the imaging techniques. So you look at these are not very uncommon in your clinical practice that you will see. There are, as I said, more than 200 conditions. I've only put up some common causes. Miscellaneous like drug-induced fever, factitious fever, thyroid metabolic disorders can present to us as a issue. Now we look at the spectrum from us. I invite Dr. Piyush to tell us about the observations made on the retrospective review.
Thank you, madam. So, good afternoon to all of you. We did a retrospective analysis of all those patients who had fever of unknown origin during the time period of January 2011 to June 2016. What we actually did, we screened all those patients who were admitted in our unit during that time period, and all those patients who had fever for duration 3 weeks or more than that. Those case sheets were taken out from medical record department. 2 of our faculties from our unit, we carefully examined all those cases who had fever for duration more than 3 weeks. They were in total 428 in numbers, and all those cases were looked for whether they fulfilled the criteria of fever of unknown origin or not. So all cases that fulfilled the criteria of fever of unknown origin were included in the study. There was 108 cases of fever of unknown origin that fulfilled the diagnostic criteria, and those were included, and the gender distribution was nearly same. Our patient was mostly younger, belonged to young age group. The mean age was only 32.3. The mean duration of illness was more than 4 months. So total duration, we had patients who presented to us with the range of 3 weeks to 2 years. Of all the patients that presented to us the intensity of fever, the low grade fever was present in about 46% of the cases, whereas high grade fever was present in the 34% of the cases. Constitutional symptom, the documented or undocumented weight loss, significant weight loss was present in about 60% of the total cases, whereas no history of weight loss was present in about 1/3 of the cases. Regarding the other associated symptoms which was present in those patients, those 108 patients, GI symptoms and respiratory symptoms. GI symptoms like nausea, vomiting, non-specific symptoms, they were mostly non-specific, and respiratory symptoms like dry cough, some amount of breathlessness was present in about 1/4 of the total cases. What is important to find that 1/3 of the total patients had no associated symptoms, whereas musculoskeletal symptoms in the form of joint pain, arthalgia, myalgia, they were present in about 1/5 of the total cases. Regarding the signs that were present in those patients, 70% of the total patients had significant pallor at the time of presentation. Lymphadenopathy, peripheral lymphadenopathy was present in about 40% of the cases, whereas either liver or spleen or both were enlarged in about 1/3 of the cases. About 43% of the total cases had no other signs at the time of presentation. Means clinical examination was totally unremarkable in those cases. So we did diagnostic workup of those cases, and diagnosis could be confirmed in about 45% of the cases. No diagnosis was reached in 7 cases. So what were those modalities that helped us in arriving the diagnosis? That is 49 were the total cases in which we could confirm the diagnosis. The histopathological examination of various tissues like lymph node, liver, stomach were useful in confirming the diagnosis in about 43% of the cases, whereas bone marrow examination was helpful in confirming the diagnosis in about 10-12% of the cases. We could confirm the diagnosis of FUO with the help of diagnostic criteria in about 1/4 of the total cases. Those were mostly the patients who presented with the diagnosis of NIIT. So in two patients we could confirm the diagnosis by echocardiography, and other modalities were used in 5% of the cases. So what was the diagnostic yield of the two common imaging modalities, that is CT scan and PET scan? We did CT scan in 84 of the total out of the total 108 cases of FUO, and we found that CT scan could suggest the diagnosis in about 3/4 of the cases, whereas in the PET scan we did PET scan in about 19 of the total cases, 19 out of 108 cases, and it could suggest diagnosis in 8 out of 10 cases. So diagnostic yield of invasive modalities, it is important to note that the bone marrow biopsy of the 24 cases in which we did the bone marrow biopsy, it was non-contributory in 60% of the cases. It could confirm diagnosis in 25% of the cases, whereas histopathological examination from other sites like lymph node, liver biopsy and gastric biopsy, we could confirm the diagnosis. It was useful in 43% of the cases. So if we summarize all the leading causes of fever of unknown origin, so out of 108 of the total cases of FUO that we came across during the study period, the total infection was the leading cause in about 52%, that is in 57% of the cases. Among those, tuberculosis was the leading cause. Two cases were of protozoan, that is Kala Jar. Other cases included hepatitis, as 2 cases of hepatitis, and there was 1 case of splenic abscess. NIID, non-infectious inflammatory disorder. Out of 24 cases, SLE was present in 9 cases. Inflammatory arthritis, some of cases were rheumatoid arthritis, some of were that of reactive arthritis. 7 out of 24 cases. 2 cases were that of adult onset Still's disease. Out of 6 other cases, 2 were that of sarcoidosis, 2 were of dermatomyositis. Malignancy was present in 20 of the total cases. Hematological malignancy was the leading cause, that is leukemia and lymphoma. Metastasis or disseminated metastasis was present in two of the total cases. So we tried to analyze and look at the data in a different way, and we classified the patient who has presented to us with the varying duration of fever. That is, all those patients who presented to us with history of 3 months duration of fever, 6 months duration of fever, and more than 6 months of duration of fever. In all cases, infection was the most important cause, but as we see that the proportion of infection is decreasing. So all the cases of FUO who had infection as a cause of leading etiology were probably diagnosed early, and the cases who had longer duration of fever, there is more likelihood of having either NIID or malignancy. And now I invite Dr. Naval sir to describe changing profile of FUO.
Thank you, Dr. Piyush, and a very good afternoon to everybody. This is the initial description by Petersdorf in 1961 of 100 cases of FUO. And we see that infections were the predominant cause, followed by neoplastic diseases and collagen vascular diseases. So over a period of decades, the definition of FUO has changed, as one of the previous speaker has mentioned. It is now emphasis on more of a qualitative than a quantitative approach of number of days. The causes of FUO differ between the Western population and the Asian and other populations. NIID or non-infectious inflammatory disorders are becoming one of the predominant cause of FUO in the Western population as the infections are going down there. Whereas in our Asian population and the rest of the world, infections still predominate as one of the important cause of FUO, particularly tuberculosis. Also, we have noticed, or as I will be showing, that there is increasing proportion of undiagnosed FUO which is being seen. So this slide here shows the trends in the etiology of FUO in the Western countries over a period of about 4 to 5 decades. And as it is clearly seen that from 1950s to the 1990s, the infections are going down, the inflammatory disorders are going up, and the no diagnosis or the number of FUOs being undiagnosed is increasing. And this is the data from the FUO causes from the Asian countries and the other countries which are mentioned here. And again, here we see infections are still one of the predominant cause. We have noticed increase in the non-infectious inflammatory disorders and undiagnosed cases, but infections still predominate. So this is just to summarize the head-to-head comparison of etiology of FUO in the Western and other countries. Now coming to what does the Indian data suggest? This slide here shows the various studies done from the various parts of India on FUO. This first study was done from Wardha. These 2 studies are done from Kolkata, that's Eastern India. This was the study from Southern India, and this was the study from Srinagar. So various parts of the country. And what is apparent here is that infections still were the predominant cause of FUO. And amongst these, tuberculosis was most important. And as we see that except one study where no undiagnosed patient was there, every patient FUO had been diagnosed of a cause. Most of the studies, about 1/4 are diagnosed as there was no diagnosis could be made. So infection like tuberculosis was most common cause among these studies, except in the study from Srinagar where brucellosis and salmonellosis was found to be more common than tuberculosis. Malignancies, lymphoreticular malignancies, particularly Hodgkin's disease and non-Hodgkin's lymphoma, were important, and among the NIIDs, SLE was the most important cause which was seen in these studies. Now coming to our own experience here at AIIMS, the 5 studies have been done from AIIMS from 1982 till 2012, and 4 of them have been published, which are mentioned here. The first study was done in 1996. This was the criteria here was 2 weeks of fever with normal chest X-ray was included as fever of unknown origin. Whereas all these 3 subsequent studies had utilized the classical definition of FUO. The point to be noted is that these 3 studies, the last 3 studies were done to evaluate the utility of a particular diagnostic modality. That is, the study in 1997 was done to see the utility of CT scan, chest and ultrasound abdomen in diagnosing FUO. This study was done to see the utility of bone marrow examination in diagnosis of FUO, and the last study, which was completed in 2012, was performed to see the utility of FDG PET in the making a diagnosis of FUO. So the trends that of the causes of FUO that we have seen in our data from AIIMS, it is very clear that infections were the most important cause and had remained the most important cause till about 2004. But in the last study, the infection as a cause of FUO has decreased substantially, and the malignancy and particularly non-infectious inflammatory diseases had increased. And one thing to note is that in the last study, about 47% of patients with FUO remained undiagnosed. Now, this data is slightly different from the data which is seen from the rest of the India, where the proportion of undiagnosed is not so much. This is more in tune with the Western data, possibly because of a referral bias that we as a tertiary institute, we get the most difficult cases of FUO, which have undergone extensive diagnosis outside, and again the investigations are repeated, but still we may not be able to make a diagnosis here. So that could be related to that. Tuberculosis, particularly extrapulmonary tuberculosis, was the most common cause in the last study, and Kala-Azar and enteric fever were the other 2 infections which were important causes of FUO. Again, lymphoreticular malignancies were more common. Other malignancies like carcinoma stomach, carcinoma prostate, only 1 or 2 cases were seen. Now, systemic lupus erythematosus and adult onset Still's disease were seen as the commonest causes in all the studies except the last study, where adult onset Still's disease and non-specific aortoarteritis cases were seen. SLE was not one of the cause of NIID in the last study. And again, as I mentioned, high proportion of subjects remained undiagnosed. Now, as Dr. Piyush had earlier mentioned about the duration of fever and its some bearing on the etiology, this was the study which was undertaken to see what is the time of diagnosis and whether it has any bearing on the etiology. So in this, the early diagnosis, intermediate and late diagnosis, that is less than 3 days, 3 to 7 days and more than 7 days. This would fulfill the classical definition of Petersdorf of FUO. This would fulfill about the modified definition. So when the data was analyzed, and we see that with delay in the diagnosis, the likelihood of neoplasms and inflammatory disorders being the cause of FUO increases as compared to infections. Now coming to the diagnostic modalities which have been helpful, Dr. Piyush has highlighted something about it in the previous data. Now I must remind you that there may be some differences the data between I am presenting and the retrospective analysis, because the retrospective analysis was undertaken of the patients admitted in only our unit. But these studies which I am quoting done were included patients from the whole department. So there may be slight differences in the data. Now the diagnostic modalities over the last 3 studies, as we see, histopathology or biopsies has been most important utility, is of most utility value because they have always given us the final diagnosis. Radiological investigations confirming the diagnosis or reliance on the radiological investigations to confirm the diagnosis has been going down. The reason is that more and more sensitive radiological investigations are being used. So increased use of these investigations may lead to increased picking up of abnormal findings. But whether those abnormal findings are contributory to the diagnosis is questionable, and that is what has been observed. The therapeutic trial, initially based on imaging, therapeutic trial was more frequently utilized as in cases of FUO because aggressive approach to intervention in interventional radiology in finding out the diagnosis, that is histopathological examination in biopsies or FNACs, it was less, which is much more frequent right now. Now, coming to the last study, the comparison of imaging modalities which are helpful in reaching the final diagnosis. And as I mentioned something about previously, that ultrasound and CT, which are more frequently used, they were abnormal in almost 70 to 80% of the patients, but they were contributory in only about 20 to 25% of those where they were found to be abnormal. On the other hand, PET CT was abnormal in about 75% of the patients where it was done, but it was contributory only in 1/3 of the patients. And it was diagnostic in 3 patients, that is 6%, because these 3 patients were diagnosed as non-specific aortoarteritis, where no other investigation would give us a clue. We cannot get a biopsy, we cannot get a tissue diagnosis. So this is just to emphasize that though radiological investigations are available more frequently, they may pick up more abnormalities, but contributory, how much they will contribute to the final diagnosis, maybe not too much. So summarizing, infections are declining as a cause of FUO, particularly in Western and also in our setup. That may be because of availability of better imaging modalities, which may pick up the hidden infections or the abscesses or collections earlier on. And we have more sensitive serological assays like for RK39, for Kala-Azar. Initially it was not available, only a histopathological examination was required of bone marrow. Availability of potent antimicrobials, so the patients are being treated and they are being cured earlier. Tuberculosis, however, still remains an enigma because it can present in any form, and particularly extrapulmonary tuberculosis still remains the most common cause in India and several other Asian countries. Non-infectious inflammatory disorders are increasing because of better awareness about the disease and better classification of the diagnostic criteria, and fever in these situations may present earlier than positive serological tests or the classical clinical manifestations. Likelihood of non-infectious inflammatory disorders and malignancy is high with delayed diagnosis. However, increasing proportion of undiagnosed cases, which may be difficult cases of FUO, which need to be further evaluated. Now I invite Dr. Smita to tell us about the role of radiology and intervention radiology.
Thank you, sir, and a very good afternoon to all. I'll be discussing the role of imaging in evaluation of the causes of pyrexia of unknown origin. As has been previously described, these causes could include infectious, inflammatory and malignant causes. Whenever we are deciding on any radiological investigation to be ordered for these patients, we should keep in mind these 3 principles. That is the ALARA principle, as low as reasonably achievable. The radiation dose should not be very high for the patient. There is a varying sensitivity and specificity range for different modalities. We should keep that in mind, and the cost of the modern day diagnostic investigations. The first line radiological investigations include the classical X-ray studies and ultrasonography. Chest X-ray is the initial starting point where the definition of PU is to be considered. However, a negative result on a chest X-ray does not preclude the performing of a chest CT. Ultrasound is a very safe modality. There is no radiation exposure. It is an inexpensive, freely available modality. The only disadvantage being that it is operator dependent. Ultrasound includes both an abdominopelvic examination and a neck ultrasound for the evaluation of common conditions like lymphadenopathy, hepatosplenomegaly, presence of any fluid abnormality, that is effusion, ascites, any focal collections or masses. Similarly, in the neck, the thyroid gland should be evaluated for an evaluation of any thyroiditis. For example, these are examples showing the presence of right pleural effusion, ascites, bowel wall thickening which can be picked up in the right iliac fossa in cases of ileocecal Cox, thyroid gland evaluation for evaluation of thyroiditis or any focal nodules, and focal pyelonephritis, just small examples to show the role of ultrasound. Similarly, in the neck ultrasound, the presence of multiple lymph nodes which have an abnormal suspicious morphology, There can be large heterogeneous lymph nodes or even the formation of abscesses. Second-line radiological investigations include color Doppler, contrast enhanced CT examination and MRI. Color Doppler can pick up disease entities like deep venous thrombosis or thrombophlebitis. For example, in this case, we can see that there is presence of thrombosis of the common femoral vein. There can be presence of iotoarteritis, that is, there can be non-specific wall thickening of the subclavian artery, and there is an absence of the normal triphasic waveform. This is what suggestive of iotoarteritis in this patient. CCT examination. CT has an excellent spatial resolution and there are multiplanar reconstructions available on the current scanners. The CT net for evaluation of lymphadenopathy, abscess or thyroid diseases. The CT chest for any suspicious findings on chest X-ray, but even a normal chest X-ray does not preclude a CT chest because it can pick up small nodules, parenchymal or pleural pathology or any hilar or mediastinal adenopathy. CT abdomen for evaluation of lymphadenopathy, bowel wall thickening or hepatosplenomegaly, and definitely for presence of any collections or abscesses or any focal masses. For example, renal cell carcinoma can also present as fever of unknown origin. For example, in this case, the left supraclavicular lymph node. In cases in patients who have obese patients or there is a short neck, palpation is difficult for the evaluation of the supraclavicular area. In this case, ultrasound or CT is definitely helpful. The left level 5 lymph nodes, thyroiditis. For example, in CCT, we can see that they classically necrotic right paratracheal lymph nodes, subcarinal lymph nodes. These areas are hidden on the chest X-ray and will not be identified on a chest X-ray evaluation. Small periportal lymph nodes or upper retroperitoneal lymph nodes, which may be missed on an ultrasound because of the gaseous distension or in an obese patient. Small centrilobular nodules, again, these would not be picked up on the chest X-ray. Miliary nodules, as seen in this case. Smaller lesions like a small liver abscess in the segment 6, a small necrotic RCC in the midpole of the left kidney, a small focal lesion in the spleen, and again pericardial effusion, ascites, a multiplanar reconstruction which is documenting almost all the findings, the thickening of the bowel wall, the omental thickening, ascites, as well as presence of pericardial effusion. CT angiography can be planned if the patient has an ultrasound which shows that there is bowel wall thickening. Then, for example, in this case, we can see the thickening of the terminal ileum along with multiple skip areas also of thickening along with mesenteric lymph nodes. This was again a case of Cox. Iotoarteritis, extensive wall thickening around the arch of aorta and the origin of the branch vessels. MR angiography evaluation showing the presence of collaterals along with thickening of the subclavian artery and the infrarenal abdominal aorta. MRI has got a superior contrast resolution. Definitely there is multiplanar imaging with direct acquisition in the coronal and sagittal planes. There is definitely no radiation exposure and much better modality for evaluation of spinal and intracranial lesions. For example, in this case, we can see that the patient had a normal CT scan. There can no abnormalities picked up in the bone window, either in the spine or the sternum. An MRI was done, and these are the post-contrast sagittal as well as the axial images, which show that there is abnormal enhancement of the marinum sterni along with abnormal enhancement along the costotransverse joints at multiple levels. This was a case of infective etiology. There was a heterogeneous enhancement of the spleen on the contrast-enhanced CT scan, but no focal lesion was picked up, which was better seen on these MRI suggestive of granulomas. Whole body MRI is a currently encouraging modality in which the entire body is scanned from the vertex to the toes in one or more planes, usually the coronal plane, and multiple sequences are required. These include the STIR imaging, the whole body diffusion, as well as the post-gadolinium T1 weighted imaging, and the evaluation of multisystem disorders can be done in a single examination. For example, we can see in this case, this is a whole body MRI in which the STIR imaging, the whole body diffusion as well as a post-contrast T1 weighted image has been performed, and there is presence of enhanced supraclavicular lymph nodes which are seen on the STIR image. They do not show diffusion restriction and their enhancement on the post-contrast images, and this was a case of reactive lymphadenitis. For the image-guided interventions, ultrasound and CT have a very important role because now we can perform FNAC and biopsy under ultrasound or CT guidance, especially for any lymph nodes or mass lesions, and aspiration of any collections, ascites or a small amount of pleural fluid. For example, we can see that this is ultrasound-guided FNAC of the cervical lymph node. Similarly, an ultrasound-guided FNAC of a mesenteric lymph node, and aspiration was done from the pleural collection and a catheter was placed in situ. Thank you. And now I invite Dr. Rakesh from the department to do this.
Good afternoon, everyone. We commonly use FDG in the PET-CT imaging, and FDG is a analog of glucose. So any pathology which shows increased glucose metabolism is likely to show up in the whole body PET-CT scan. And we have done one spectrum to see the spectrum of FDG PET-CT findings in patient with FUO, and this was a Atlas article, and total 48 patients were involved, and we could localize the pathology in 50% of the patients. Among these 50% patients, about 1/4 were infective, and neoplasm was found in around 12.5% of the patients. The conclusion of the study was that PET-CT is very sensitive for the diagnosing of infective and inflammatory pathology, as well as very useful for the neoplastic pathologies, so it can be used. I show some cases. This is patients with 70-year male with fever, cough, and weight loss, and you can see there is a subclavian artery uptake and carotid, and this is ascending aorta and descending aorta FDG uptake is there, and this was diagnosed as a large vessel vasculitis. This is another patient, 61-year-old male, presented with fever more than 2 months. CT shows hepatomegaly with bilateral adrenal masses, and on the FDG PET, there was no abnormality in the liver. However, both adrenals were enlarged, showing increased uptake with area of necrosis in both sides, and histopathology diagnosed as a histoplasmosis in this case. This is another patient with the classical case of sarcoidosis, and this is a Greek letter word lambda, and mediastinal lymphadenopathy is there, which is showing uptake. There is a bilateral hilar lymphadenopathy, subcranial and paratracheal nodes are showing increased FDG uptake. So it's very useful for this is lambda sign is classical of this sarcoidosis. This is patient 46-year-old male presented with fever more than 2 months, and you can see thyroid is enlarged with the diffuse increase FDG uptake. There was a mediastinal lymph node also showing some uptake. So we gave that it is a possibility of thyroiditis, and with clinical correlation finally it turned out to be thyroiditis. This is interesting patients with 26-year male with fever more than 2 months. PET showed generalized lymphadenopathy, bilateral axillary lymph node are there, and then multiple bone lesions were there. If you see lytic lesions are there in the vertebrae, so multiple bone lesions were there. We mentioned that there are multiple lymph node and bone lesions, especially lytic lesions. So normally, if it is a marrow lesions, we can consider it could be a lymphoma, but lytic lesions, especially bone lesions without marrow involvement, we have given possibility of TB, which turned out to be on FNAC, one of the node. This is another interesting patient, 35-year female, known case of rheumatoid arthritis in remission, and now presented with undiagnosed fever, and there was subcutaneous swelling were there, and there were multiple focal area of increased uptake noted in the whole body PET-CT scan. And if you see, there were multiple subcutaneous thickening, which was showing increased FDG uptake. So based on the generalized subcutaneous thickening, a possibility of paniculitis was made, which was confirmed on histopathology later on. This is a patient of 26-year female presented with fever with cervical lymphadenopathy, and in this case there were bilateral axillary lymph node, and PET-CT showed spleen is enlarged with intense FDG uptake. There were multiple bone lesions, multiple retroperitoneal lymphadenopathy was also there. So we said there was possibility of either lymphoma or TB. A node for biopsy was taken out, and it turned out to be a high-grade non-Hodgkin lymphoma. This is what Dr. Nawal mentioned. This is one study was done as a MD thesis. Total 47 patients were involved in this, and PET was contributory around 40% of the patient in this study. This is, we have just done a retrospective analysis of patients who are having suspicious of large vessel vasculitis, and a total of 40 patients are involved in this. Of these 40 patients, 14 patients had FUO, and FDG PET was positive in all, and after treatment 32 patients showed complete response and 8 patients showed partial response. The result of this FDG uptake correlated with normalization of serological markers like ESR and CRP, and it was very well correlated. This is classical example of how aortoarteritis looks. This is descending aorta, increase FDG uptake throughout the descending aorta. This is pre-treatment, and this is post-treatment. You can see the response here, and this was done after 6 weeks of immunosuppressive steroid therapy. PET-CT is also very useful for inflammatory bowel disease. Sometimes can be a cause of unknown fever, and this is study done with gastroenterology and radiology, Dr. Chandan, and we have demonstrated that PET-CT enterography or PET-CT colonography can be used. And here's one example. This is colonoscopy image, and you can see ulceration, and there is a uptake, small area of uptake. This is patient with rectosigmoid ulcerative colitis, diffuse wall thickening with increased FDG uptake. And this is interesting patient. This is father of one of the faculty of AIMS, presented with fever of around 2 months, and we could not do anything except lastly PET was advised to find out anything, and we found that there was a bilateral cervical mediastinal lymphadenopathy, and the pelvis also you can see lymph node, and Dr. Sanjay Thulkar did the biopsy and turned out to be a allergic angiitis Stokes-Strauss disease, and this is pre-treatment scan. Patient received immunosuppressive therapy, and you can see post-treatment, and patient was afebrile after the steroid therapy. This is patients with pre-treatment sarcoid patient. You can see classical that lambda sign. This is pre-treatment and post-treatment also. PET-CT is also useful for guiding the biopsy site. It can be done under ultrasound or CT, and we also do when there is a large lesion, and many a time you don't get the proper tissue. You can see you get only necrotic tissue, so we can take a sample from the most active site. This is an interesting slide. I have copied these two algorithms from Harrison, and you can see the first one is 18th edition, which published in 2012, and this is recent edition, 19th edition, published in 2015. So in this, CT of abdomen, chest and pelvis was the first line of modality for PUO, and if it is a negative, then PET-CT was used to done. Now things has been changed. Now PET-CT is the first line of modality, diagnostic modality, and if it is negative, then only you should do a CT chest or abdomen, CT or pelvic CT. So this has been changed. I found out this is a recent meta-analysis which published online in June 23, and this is study of collection of data of more than 1,000 patients in 22 studies, and diagnostic yield of PET-CT was around 60%. And the conclusion of this meta-analysis that PET-CT could be considered as an inclusion for first-line diagnostic workup for these patients, especially when infective and neoplastic causes are more common. This is one of the review article I was asked to write for the CMR, which is having very high impact factor. And finally, the conclusion for PUO for the role of PET-CT is for the diagnosis, especially when you are looking for non-specific aortoarteritis. It can guide the site for the biopsy, and also it's very helpful to see the extent of the disease. Many times you see on the ultrasound CT there is a retroperitoneal lymph node, so we can do the which is most accessible lymph node or the another tissue. It can be also useful for the treatment response. Thank you very much for your kind attention. Now I invite Dr. Rama.
I'm really short of time. So I think whatever everyone has done, the final diagnosis comes to microbiology. So microbiology has to put a stamp that whether it is a tuberculosis, typhoid or any other infection, and that is where our role comes. So I'm just giving few examples where microbiology has been able to pinpoint the diagnosis where the clinical diagnosis was something else. And this was some of the cases we reported in American Journal of Medicine, where actually this case presented with hepatomegaly, fever, and initially, there was differential diagnosis of malaria, leishmania, disseminated tuberculosis, and even hematological malignancy. And that was the time when we started PCR for typhoid, and samples were coming to us. And similarly, this another case too, which also was diagnosed as disseminated tuberculosis. So both these cases were actually subjected to the multiplex PCR for detection of salmonella. And this was very unusual case presentation. Usually typhoid does not present with pulmonary manifestations, and we could confirm the diagnosis by PCR. And it was only after 7 days of bone marrow culture that Salmonella paratyphi A was identified in both the cases. And this kind of unusual presentation we have been able to find out only because of the application of molecular tools. Then we had another case which again now presented with fever, and this person happens to be my collaborator father, and therefore very intensive investigations were going on. We were trying to look for all causes possible in this case, and there was pulmonary presentation, so we thought maybe it is also turning out to be typhoid. But to our surprise, all these cases, all these samples which are subjected to cultures, PCR and all other tests were negative. And we were also, that time reports were coming from Port Blair about the hemorrhagic pulmonary manifestation, and we started looking for leptospira by PCR as well as by some rapid tests, and all the tests were positive in this case, and this was the first case of pulmonary leptospirosis reported from Delhi that time. Then we had a long series of 10-year study published in IJMR, where we studied from 200 to 2000 to 2010, and we have reported approximately 27% positivity by ELISA, and these samples were then subjected to PCR and also MAT, which is a confirmatory test for the leptospirosis. So before these studies we were doing, for 40 years there is no data for leptospirosis from Delhi. So this was a study which we started, and we were able to report many cases, and they could be subjected to specific antimicrobial therapy. This was a very interesting case. The patient was malaria positive, he was dengue positive, and also hepatitis E positive, but patient was not responding to any treatment, neither to antimalarial, and even though the dengue was there, patient was still having fever, and that is where we demonstrated leptospirosis, this detection again by PCR and serology, and patient responded to the antibiotics, and that's what we reported. Sometimes there can be more than one infection, so we should not just close our eyes and think the diagnosis has been made. If patient is not responding, please look for other causes. This is the study we have done from 2010 to 15, another 20% positivity. And of course, these are the classical presentations, myalgia, jaundice, splenomegaly, and other things. But we are seeing the cases where there is more of respiratory symptoms now. So in this particular series, approximately 20% presented with respiratory presentation. Then this is a new infection. I will say new because in India no work has been done, and we started working on Bartonella infections just to think that if the PUO can present with this particular infection, and these are the 3 modalities we are using. And in a small series we have done, we could report 9 positive cases, and of course 8 were children in this particular group. And this is, a kind of emerging infections in India, and now the diagnostic tests are available in our department. Then further, this is just the PCR. Another, cause which you have seen in PUO is rickettsial diseases, and just 2-3 years back we had no report of scrub typhus from Delhi. Of course, there are few reports from South India, and this is a study. The student has done this study, and he has reported almost 33 cases of scrub typhus from Delhi, and presenting with varied presentations. And so much so that in this 423 cases we have done so far, like we could get almost 10% positivity, and out of the 41 again many are children, And just from medicine, we have reported approximately 26 patients of scrub typhus. So, keeping this in view, there are many other tests which we are not looking for. Either we are not aware, or we are not thinking of those diagnoses in the very beginning, or we, kind of the diagnostic modalities are not available. So just to inform you that we have tests available for rickettsiosis. We are doing for scrub typhus as well as for all other rickettsial diseases, and also the test available for Lyme's disease, where some patients have been reported from rheumatology by Dr. Uma Kumar. And so this is another, disease we should keep in mind in addition to what we have said already. And just to highlight that now in microbiology we have a lab called special pathogen lab. So all those unusual causes which we were not looking for or investigating earlier are available, and these tests can be done now. Only thing is, the request is, the last slide, that please send us the samples right in the beginning and not after ruling out all other known causes, because it's very important to have the first sample. Then also we need a special sample, EDT or citrated blood for PCR, and as well as serology, both first time as well as in follow-up whenever you are having patient, to give a confirmed diagnosis. Thank you so much.
Next. Thank you all. Now, in the for any diagnosis for clinicians, pattern recognition is an important thing that we learn with experience, and it is something which contributes to diagnosing various conditions. But in the case of FUO, I would like to read this statement from a seminar on FUO. It says, FUO defies simplification. Reported causes exceed 200 and fall into diverse subspecialty categories. There are no algorithms and few clues that reliably suggest or exclude particular diagnosis. The clinician must rely on very careful evaluation and detailed knowledge of a wide variety of diseases. We heard a spectrum of conditions, particularly specific modalities, dealing with different case issues, as you saw. And we also looked at the common causes. If you looked at, most of the causes were not very rare or esoteric. They were the common illnesses, but presenting very atypically. I mean, there's no reason why you can't diagnose a Kala-Azar from usual investigation. But these are the patients who present very atypical. I still remember 2 or 3 Kala-Azar patients who were diagnosed only on postmortem from liver biopsy, where we saw antibodies only in the cells of liver. So these are atypical presentations, and that is why they defy, they elude us, they elude all the investigations. So what is the approach? In the next 3 or 4 minutes, I'll just briefly summarize the approach. What should be our approach? Very important to rule out what we call the little tree. We very often, you would have noticed, the residents, particularly in the OPD, we say, let us document fever. Patients come to us with low-grade fever going on for years, months and years. We say, let us document, and we admit them, and we find they don't have fever. Or you tell them to maintain a temperature chart, and they come to you with something that says 98.6 degrees, and it's not fever at all. So documentation, so that to rule out cases of fictitious fever. We do have cases of fictitious fever. We've seen 2 patients of health care workers, where there was even malingering. So documentation, temperature chartings and settings will rule out these conditions. And the other thing is drug fever, particularly patients who have been on many drugs. And drugs as, simple drug like nifedipine, we've seen patients drug-induced fever due to many cardiac drugs. No drug is immune. So if they are non-essential, just stop all drugs and watch. So the diagnostic approach then would, after you ruled out these, and of course you ruled out nosocomial, and we're not talking about nosocomial, we're talking about classic FUO. The first stage is screening. Patients come to us with a big pile of investigation. Don't undermine the importance. Just review the whatever has been done before. So review the history and physical findings. There are many patients where sometimes, second time, third time history, and you get a clue. So we had a patient who had undergone extensive evaluation, including CT, bone marrow, all, I think even liver biopsy. This was long ago. And then on questioning one day, we said, do you have any problem in eating? And then he said, no, we khata hu to thora dard. And we said, oh, are we dealing with giant cell arthritis, which we never saw before. So we did a temporal artery biopsy, and we were rewarded. It was a giant cell arthritis. Patient is now on 15 years of follow-up, doing very well. So just review the history and physical findings. As we said, subtle clues. Even if patient says trivial pain here and there, particularly areas which are not amenable to a good examination, is something that patients very often, we've had patients, ischiorectal abscess, from years FU, but they don't reveal. So a good examination can pick up. So that would be the first step, screening, review the history and physical findings, do it again and again, sometimes even doing 2 weekly X-ray chest, pick up miliaries and a lymph node appears and it can give you a clue. Rule out the little three. The step 2 would be non-invasive approach. We listen to the yield of various investigations. And of course, it depends a lot. We heard the diagnostic yield of various imaging modalities. It depends a lot on what is your pretest probability of getting positivity. That would decide actually the yield. Now, it's also true that when we are using this right and left as the first modality, you do pick up some subtle or non-specific finding which actually sometimes can take you on a tangent. And you don't, so it can be, sometimes potentially diagnostic clues on investigations can be a red herring and can just misdirect you. So that's why care is needed to correlate clinical with investigative results. So CT scan, chest and abdomen of course are very valuable as we heard from Dr. Smita. And of course then CT of other sites based on the history, based on the suspected diagnosis. Echocardiography, yes, if they have a murmur for example, particularly radionuclide imaging, relevant bone films, MRI, FDG PET, we've heard this. Stage 2, as I mentioned here, it is stage 2. As Dr. Rakesh mentioned, and as the new Harrison says, FDG PET is mentioned as a first-line investigation because it is something more sensitive. It may not be specific, but it is sensitive and can give you a clue. But as far as our country is concerned, our resources are concerned, and the cost consideration for us, and as we saw in our study also, only 3 patients where it was only the FDG PET which contributed to diagnosis. So therefore, for us, it is still a second-line investigation. That's what our take would be at this point. Maybe in future, when it becomes cheaper, maybe. Then an invasive approach. Now, you see, when I was a resident, bone marrow used to be a standard investigation for everybody. We did not have all those imaging modalities. But in today's era, we'll say invasive workup only after you have done a basic minimum non-invasive workup to give you a direction. Supposing patient has anemia, pancytopenia from the beginning. You don't have to wait for CT. That's where you will think of doing a bone marrow. So get directed by investigations that you see. So preliminary investigations hold a key to what you do next. So that's very important message, particularly for residents and students. Please don't write, even in the examination question, write up to the MRI for every patient. Don't decide on a CT on day 1 when the patient is admitted. See what you're going to do in the next 24-48 hours. Get a preliminary result and then take a decision. We see very often on day 1 in the PMR, CT chest comes as one of the modalities. So please, that is something not as a first step. Do the screening and then decide where you are leading to. So beware of the need for selective testing. This is something we should avoid, a fishing expedition. So of course, in place of biopsies, if there are possibilities, wherever we can do FNACs and cytology, less invasive procedures. And stage 4, I would say, and this is again, stage 3, you get directed in specific circumstances. We have patients who have shown us a lung nodule, maybe somebody who needs a bronchoscopy, somebody who needs a gastrointestinal endoscopy. So selective radiographs. We have cases of dentoalveolar abscess presenting to us as fever, chronic sinusitis. So just get directed. Rest of the investigations we would say would be non-invasive also, be directed based on what you. In the West, bone marrow and liver biopsy are 2 blind procedures where you may not have any clue, and these are 2 blind procedures which have been used as a diagnostic modalities, and liver biopsy has shown great yield earlier, but now because of the safety consideration, patients who do not give us an answer by the rest of the modalities and you have elevated alkaline phosphatase, do have a clue to the liver involvement, those are the patients we would consider. Certainly it has a high yield. But temporal artery biopsy, in contrast to the West, we do not do it as often. We've done it in very select patients. But in the West, it is suggested as a routine blind biopsy in any patient who has high ESR and is elderly, who presents with fever, because it's one of the commonest causes they see. Okay, the next step would be, we still fail to get a diagnosis, and supposing a patient is having, there are a lot of patients who come to us with general rule, what we say is a benign FU, so-called benign FU. People who have gone on with low-grade fever for years together, it's very likely that we're not dealing with something serious. So these are the patients who can be observed, re-evaluated at frequent interval, tell them to regularly follow up, tell them to come if they have any new sign or symptom. and re-examination may give you a fruitfulness rather than being aggressive. And role of therapeutic trial. Now, this is something again, as Dr. Naval mentioned earlier, when we saw imaging typical features and we will subject them to therapeutic trial with ATT. It was considered a diagnostic test, but not any longer, because we try to get a definite diagnosis as much as possible. But then when patient is deteriorating, patient is sick, there are situations where you have to take these decisions. And yes, these are the three modalities which are often used. Of course, antibiotics if there are any clues or if there is a shorter history, antituberculous when you have some sedation based on the imaging, and corticosteroids, but they are the last resort. Now when we start a patient on therapeutic trial, the two things I would like to see particular residents follow the rules. One trial at a time, giving full dosages and giving full duration before you say it's not effective. Secondly, responsibility of the clinician increases when we start the patient on therapeutic trial. That's not the end. We need to follow up, and we need to know our responsibility actually increases when we send undiagnosed patients home on therapeutic trial. Because the close follow-up is very essential to know whether we are on the right track. Prognosis would depend on the underlying cause. I would not say undiagnosed cases. We've had patients who have actually died with no diagnosis. We've had patients where we've been able to do postmortem biopsies, and most often what we found is leukemias and lymphomas. People who have died and we've been able to get a biopsy, and there are some who have lost to follow up. But it depends on the underlying disease. I would just like to conclude quickly. I know we are short on time. It's important to remember that it's more commonly an uncommon presentation of common diseases rather than rare conditions. So think of common things first. Extrapulmonary tuberculosis, still the commonest cause of FUO, though non-infectious inflammatory disease seems to be increasing over the years. Repeated clinical evaluation often provides important clues to the final diagnosis, and therefore a repeated evaluation is something we should not shy from. And judicious use of various imaging modalities and investigation is advisable. And even low-grade fever. Though you see the definition Western 101, please remember that in our country, extrapulmonary tuberculosis is very common, and sometimes it may signify, so do not disregard. And it's important to recognize benign FUO in order to save patients not only from unnecessary workup but also a lot of anxiety. Now, FUO is a condition which requires a lot of patience, perseverance on the part of physician as well as the patients. And thank you very much. We come to a formal end of the formal grand round, and I acknowledge all the speakers, all the departments who have helped us in diagnosis, all the residents who work very hard to actually get the diagnosis in these patients, and my faculty colleagues. Thank you very much. I know we have short time, but if there are one or two questions, yeah, we have planned.
Question. About 100 plus patient, 60% of the patient had X-ray abnormality. So
Which one?
Among 104 or 6 patients, we need FUO for letting in
The huge what you
yes. So 60% of the patient had X-ray abnormality, and 68 patient has ultrasound abnormality.
No, sir. That was from the
Then the X-ray abnormality is rule
All
of FUO. I think you are mistaken.
in all the
X-rays were normal in all the patients. That was the criteria for inclusion.
Sir, of all the 428 cases which we have taken out from the MRD, we have excluded all those cases that had X-ray abnormality that has led to the diagnosis or
I think there may
ultrasound.
be some. There is all these having strictly adhere to the criteria, which means an X-ray and ultrasound screening investigation for normal.
Nobody showed a chart on this. Charting fever is important. Nobody showed a chart on various kinds of intermittent, remittent, continuous. I think that's a very important, that's a very basic yourself exercise in the slide. And because that is, I think, the first line.
Yeah, I agree, but see, when it comes to FUO, we have done in the initial years correlations. Now, listen, correlations on patterns of fever with diagnosis. So this is not something in today's era to be relied on the pattern of fever. That's why I said, don't underestimate low-grade fever. It is not a pattern of fever. It tells us this is malaria. वो पहले ज़माने में होता था alternate day, cotton fever, malaria. No, this is not something we see. So I agree that for students and future child, let's see the voice.
I agree, maybe things have changed now, you mix infection. But basic charting, man, that still doesn't go off. You do the chart and you get a pattern. I
That's what we say. Bartolo fever has not shown much correlation except for the low
I mean,
grade.
now it's gone out to Hodgkin's if you
Oh, well, at least fever, yeah, we no longer
Actually,
see
We no
that.
longer see that.
It's not, it's got a very low sensitivity. No, I'm saying that it's not very low sensitivity, but yes, we do see relapse. Not denying that. See, dying was a limitation. We could have said not.
Yeah, I know.
Any
Anyway, thank you.
questions?
That's very good. One question, which is the first thing.